Hi everyone, welcome back. I'm Pooja, and to continue our oral radiology series for the dental hygiene boards, we will cover the different types of radiographs. Let's get started. Alright, so when we talk about the different types of dental x-rays, we can actually break them down into two main categories. First, we have direct or intraoral x-rays, and that just means the receptor is placed inside the patient's mouth, and the x-ray photons then directly hit the receptor and form the image. Common examples are periapicals, bite wings, and occlusal radiographs, and all of these give us different information based on what we're looking for. Now, the second type is indirect or extraoral x-rays, and in this case, the screen or the receptor is actually placed outside of the patient's mouth, and the x-ray photons first hit the screen before they make their way to the film or the sensor. And you've probably heard of panoramics, cephalometrics, and CBCTs, which all fall under the indirect x-ray category. All right, let's take a closer look at each one. All right, let's get over our direct and intraoral x-rays again. The first one is the periapical, and this one captures the entire tooth, including the root apices. It's super helpful for detecting caries in the front teeth, and it's also important for checking out the root structure, the surrounding bone, and any other possible pathologies that can exist around the tooth's root. Next, we have the bite wing, which can be taken either vertically or horizontally, and unlike the periapical, this one doesn't show the root tips. The vertical bite wing is especially useful when we're looking at bone loss and alveolar crest assessment, especially for implants or for crowns, anything like that. And finally, there's an occlusal x-ray, and for this one, the receptor is placed on the biting or the occlusal surface, and it gives us a nice view from canine to canine. Let's talk a little bit more about indirect x-rays. Talking about indirect or extraoral x-rays, the first one up is the panoramic, which many of us are very familiar with. We may have had some taken on ourselves, or we may have taken some on patients, and this one involves the machine rotating around the patient's head to capture a full view of all the teeth and the jaws in one single image. And the next one is a cephalometric x-ray, which comes into two main types, the lateral and the posterior-anterior views, and this gives us important information about the patient's head, their facial structure, and in this image there's also a ruler which corrects for linear measurement magnification. And this is the best x-ray for orthodontic cases, and if you've had ortho treatment in the past, you may have had this type of x-ray taken on you. And finally, there's CBCT or cone beam computed tomography, and this one gives us multiple detailed views and is especially helpful for implant assessment. But with that said, the CBCT isn't the only option for implants, and many clinicians actually use a combination of a CBCT and a panoramic to get a general overview of all the teeth and the jaws, or a CBCT and a periapical to check out root structure and bone health, but usually we typically don't need a lateral ceph for implant planning. So, key responsibilities for dental hygienists include capturing radiographs that allow for accurate diagnoses. And a very useful technique to achieve this is to use the buccal object rule, and it's also called the SLOB rule, or the same lingual opposite buccal rule. And this method really helps us to determine the relative position of the roots, the canals, or any other structures when they overlap on a 2D radiograph. And so if we want to apply this rule, we always need two radiographs with different horizontal angulations. So for example, if a mandibular molar is undergoing root canal therapy, the files are placed in the canals and the radiographs obtained will clearly show whether a file is in the mesiobuccal or the mesiolingual root. Here is the first radiograph, and notice how the two mesial roots overlap on the image. It's really difficult to tell which file belongs to which canal, and this happens because radiographs project a 3D tooth onto a 2D flat image, and this is what causes superimposition of the roots and the canals. So the buccal object rule really allows us to separate these overlapping structures by changing the X-ray beam angulation so we can make a more accurate interpretation. So now let's apply the technique. If we shift the X-ray tube mesially, the image changes. And here's the rule. The file or the root that is closer to the lingual surface will appear to move in the same direction as the tube shift. And the file or the root that is closer to the buccal surface will appear to move in the opposite direction of the tube shift. So in this example, after a mesial shift, the red file also moved mesially, and this identifies the mesiolingual root. And the green file moved distally, so this identifies the mesiobuccal root. To summarize, if the image of the file or the root moves in the same direction as the tube shift, it's on the lingual side, referring to the same lingual portion of the SLOB or SLOB method. If the image of the file or the root moves on the opposite direction, it's on the buccal side, or referring to the OB or opposite buccal portion of the SLOB rule. So understanding this rule is valuable not only in endodontics, but also when we interpret radiographs for periodontal involvement with multi-rooted teeth, when we evaluate impacted or supernumerary teeth, and also when we identify foreign objects or anomalies. And this principle works no matter which way we shift the tube. For example, if instead of moving mesially, we shift the tube distally, the same rules apply. The lingual file, or the file in red, still moves in the same direction as the shift, and the buccal file, which is in green, still moves in the opposite direction. So whether we shift mesially or distally, the SLOB rule helps hygienists capture and interpret the radiographs that give a clearer view of the root and the canal positions, and this improves the accuracy of diagnosis and treatment planning. So when you're taking x-rays, mistakes can definitely happen. I've had my fair share of mistakes, and it's really important for us to understand why they occur and how to fix them. So let's start out by talking about some common intraoral radiographic errors. The first two that we're talking about have to do with exposure, and one big factor is exposure time. If the exposure time is too short, you'll end up with an underexposed x-ray, and basically this means the image will look too bright or washed out. On the flip side, if the exposure time is too long, you'll get an overexposed image, which will look much darker than it should. Alright, so next up we've got a cone cut error, and this usually happens when part of the sensor or the film doesn't get exposed to radiation, and it's usually because the x-ray beam wasn't aimed correctly at that sensor. So as a result, you'll see a blank or a clear area on the image where nothing was captured. And another common error is overlapping contacts, and basically this means spaces between the teeth aren't visible, and the teeth look like they've been stacked on top of one another, and that means that the horizontal angulation of the beam was off. So students, if you look closely at the image on the right, can you spot anything else that may look a little odd on the radiograph? So one thing that I like to point out is that the teeth are in occlusion, and ideally we want them slightly separated and the patient not biting down really hard on the sensor, because with that little bit of space, it helps us to capture the interproximal areas and the occlusal areas very clearly. And speaking of angulation, if the x-ray beam is two angles in relation to the teeth, we may have foreshortening where the teeth appear shorter than they are. Now the counterpart is elongation, where you can actually see the teeth appear longer than they actually are. Moving on to the most common panoramic radiographic errors, the first one is failure to remove external objects. And in this case, we have earrings, which can be seen on our panoramic x-ray, and this caused a ghost image. A ghost image is a blurred, magnified duplicate that appears on the opposite side of that object. So for example, the large earring seen on the right side is actually a ghost image of the left earring. And this differs from an artifact because an artifact is any distortion that is caused by factors like patient motion, equipment errors, or improper positioning. We can also have the patient positioned inappropriately, which can lead to a wide array of errors. So if the chin was positioned too up, the image may show more of a frown face than normal. On the other hand, if the patient's chin was positioned down, the image may appear as a joker, or what I think is a pretty creepy smile. If the patient turns their head during the panoramic scan, we can end up with an image that looks like this one. And in this case, you can see that the head was rotated to the left, and you'll notice that the premolars and the molars on the left side look blurry, and they also look a little bit larger than they normally would. And on the right side, you can also see that the cervical spine and the occipital bone are not centered. They're positioned asymmetrically, which is yet another sign that the head wasn't aligned properly and that there was a little bit of rotation during the scan. If the head was tilted, we may see a panoramic like this one, where the left mandibular angle and the condyle is in a lower position, and the right mandibular angle and condyle is in a higher position. So overall, the image looks like it's kind of tilting downwards to the left side. And the last positioning error is if the patient has a slumped posture. This pronounces the cervical spine, which results in an artifact on the chin and the incisor region. If the patient doesn't press their tongue up against the roof of their mouth during the scan, we often see this dark band or the palatoglossal airspace over the roots of the maxillary teeth. And lastly, if the patient fails to remain still, and this happens in the case of perhaps pediatric patients who are scared of the panoramic machine, or someone who may just have a difficult time standing without support, as they're having the panoramic taken, it can result in a blurred or distorted image. And in this pan, the mandibular canine and premolar area on the right side appears to be blurry compared to the left side. All right, that is all the content for this video. Let's go ahead and test our knowledge. Our first question asks, what is the likely cause of a reverse smile occlusal plane on a panoramic radiograph? All right, students, take a second to pause and to try the question. Okay, let's take a look. The correct answer here is D. The patient's chin is tilted too high. If the patient's chin is tilted too far upward during the panoramic imaging, the image will show a reverse smile line with the mandible appearing widened and the maxilla narrowed. All right, so as we come to an end, let's do a quick recap of what we went over in this video. So we went over how dental x-rays can be direct or indirect. And lastly, we learned how external objects and incorrect patient or x-ray positioning can lead to radiographic errors. All right, guys, that's it for today's topic. Thanks for watching, and I'll see you next time.